Hello, everyone. I'm Tina,
I'm Whitney.
and this is Nurse Leadership Solutions, having the joy within the journey on the road today.
On the road again.
On the road again. You don't want us to sing. Actually, she's not too bad, but I'm pretty rough. We are at East Central College in Union, Missouri at the Senior Expo, and we're excited about it.
We are. This is our first time doing something like this.
Yes, first time on the road for us. So forgive us for our flaws, and let's just have some fun today.
Let's do it.
All right. See you soon. Hi, everybody. It's Tina again, and I have with me Chris from Heartland Hospice.
Good morning.
Thank you. So I want to learn a lot about hospice today because I think that there's a lot of myths about hospice.
Okay.
So tell me first about Heartland and what how you got into hospice.
So Heartland is a part of the Gentiva family. Gentiva is the #1 hospice provider in the United States. They own several different companies, Heartland being one of them. I've been with Heartland Hospice now for almost 3 years. Prior to that, I had a home health agency for about 15 years where we took care of the elderly and the disabled in their homes.
Mm-hmm.
And so hospice was just an easy fit to go right into. As you know, in life, there's 2 guarantees, and that's taxes and death.
Yes.
And so with hospice, it just kind of seemed like the right fit because everybody can benefit from it.
Right.
It's a benefit that people started paying into as soon as they started working. Whenever you look at your wages, you see right away all the different things that Uncle Sam takes.
Mm-hmm.
And part of that is for the Medicare benefit of hospice.
Mm-hmm.
And so people don't realize that they've been paying into this benefit all this time. And if they don't use it, then the government keeps it. And hospice is a great benefit that helps with medication that is related to a primary diagnosis. So it covers all of that for free. It covers your durable medical equipment. So any kind of equipment that you might need to be able to be at your home
Like a wheelchair,
safely.
bed,
Correct.
rails. Okay.
Right. And even specialty items like Hoyer lifts and low air loss mattresses and Broda chairs. And so all those things are beneficial. Supplies are also covered under the hospice benefit. So like pads, chuck pads, gloves, any kind of personal hygiene stuff that you would need. All of that's covered under the Medicaid or the Medicare benefit of hospice, and people don't realize that. And so it's a shame whenever it's not utilized in a timely manner.
So how do you go about see that most people get started with hospice?
So hospice is determined upon a doctor who says that you have a diagnosis or a prognosis of 6 months or less to live. Now, I know people hear that and they automatically always think this is a death sentence, and that's not necessarily the case. Sometimes we get into a home or a facility, and hospice, we take care of people wherever they call home. So we've had homeless people, we've had people living in a shelter, we've had people living in a hotel. And so hospice is provided wherever they call home. And once we have that doctor's orders, then we have a nurse come and do an evaluation to see if another doctor, so there's going to be 2 doctors signing off on this, to see if they also agree with that prognosis. Once it is agreed that they are hospice eligible, then we have a nurse come and do an admission. And once we do that admission, it's told to the patient and the families that we have a group of people that help provide services. So that way you have a great amount of care for help, and that being home health aides come in, social workers, chaplains, volunteers. We have a bereavement coordinator that does pre and post bereavement. And so those are all our ancillary providers that help with our hospice care.
Yeah, and that's a difficult time. One of our previous episodes, we talked about that time period where there's so many decisions to make and so many emotions running, that to have people that have experienced it and are experts in that are perfect. So, but I do think that people that hear hospice automatically think, I must be dying tomorrow.
Right.
And I think that's a negative thing that they that has been put out there. Of course, I'm from the senior living industry, so, you know, we've had some negative things out there too, so I totally understand. But I have seen many people that, you know, treatment is some kind of treatment happens, or, you know, God intervenes or
Correct.
whatever happens, and
Right.
they live past 6 months.
Absolutely. We are not going to advance or slow down anything that is conduced by God in any kind of way. So we help with the natural progression, however that is. President Jimmy Carter was a big proponent of hospice. He was on hospice and he lived a year and a half, almost 2 years on hospice care. Sometimes we have people on hospice and we discharge them because they've gotten better. Sometimes it's they just need to get their medications right again. Because as we know, as you advance in years, sometimes your memory isn't as great and they might be taking their medication incorrectly. And so just a nurse coming in to help take care of that medication oftentimes helps them to get back on track.
Absolutely. And just having, I'm a nurse by background,
Mm-hmm.
and my dad is on an extreme number of medications.
Mm-hmm.
And just me packing his pills every day and talking to the doctors about adding and taking away and quit messing around with them.
Mm-hmm.
Having that nurse oversight sometimes a lot is about his comfort level because he
Right.
gets short of breath or hard to get around or different things. And so he's not on hospice, but he has and someone said yesterday, do you have an in-home nurse? And he's like, yes. And I'm like, well, kind of.
Is that you?
That's me. I'm his in-home
Right.
nurse. But overall, it's amazing the difference of he's had
Mm-hmm.
by having a nurse really look at that. And I'm close to my dad, but I really didn't ever get in his business
Sure.
until I started like, okay, we've been in the hospital 6 times in the last 2 months.
Mm-hmm.
I'm going to have to step in here.
Right.
And so that having that, you mentioned that struck a nerve with me because
Mhm.
I'm just like, he has greatly improved. We might have felt like we could have put him on hospice last year, but
Mhm.
he did have that improvement. One thing that you said I find interesting. So I'm from the skilled living world. And when I was a director of nursing
Mhm.
or administrator, I never understood why we would need hospice in addition to the services we're already providing
Mhm.
because I was their nurse.
Right.
Sorry, I'm throwing myself under the rug right now. I know. I was their nurse and we were with them 24 hours a day. So why would we need additional nursing?
Mhm.
But as I grew in my nursing, I did understand that. So can you talk about that a little bit? Because I think that's a misconception that
Mhm.
maybe sometimes even the senior living community fights
Sure.
or disagrees with. That is still a great benefit, even if they're living in a community.
Correct. Yes. So it's not a myth, that there is a major shortage of nurses
Mm-hmm.
right now. Home health aides, the same. And so anytime you can get an extra set of eyes, anytime you can get an
Right.
extra set of hands, it's always so very beneficial. And whenever you have hospice coming in, you have people that are skilled with the process of death and dying,
Mm-hmm.
which I know sometimes people think is morbid, but actually it's a beautiful gift to be able to give someone.
Absolutely.
Because we're all about comfort care. We're all about making sure people aren't there in pain. And so the reason that it would be beneficial to have an extra set of nurses, home health aides, social workers, chaplains, volunteers, is because all of them work collaboratively as a group. We have meetings every other week about every single patient on our service. We go over medications, we go over diagnosis, we go over about how they are doing mentally and physically, so that way we can provide the best possible care for those people. And so whenever you do that, it's such a benefit to that person because as a nurse of a facility, you're spread in so many
Right.
different ways. And if you have a census, heck, if you have a census of 15 or more,
Right.
you're
they
that
could have
nurse.
up to 40 patients.
Correct.
And yet the hospice is focused on that one.
Exactly.
Mhm.
And we have a direct link to a physician who is a hospice physician
Mm-hmm.
who understands that process that we can get a hold of anytime, day or night, 24/7. And so it's such a benefit to be able to do that. And not that you can't with the facility, but sometimes they're busy. Most of our physicians have a private practice as well. And so between the two, they work collaboratively to be able to provide good quality care.
Yeah. I 100% agree. I do definitely see that there is benefit there that I
Mhm.
might have been hoarding my people from in the beginning. I promise I didn't do that very long, but I definitely see that the benefit is there because my grandmother ended up being on hospice, and having that nurse that was there and understood that about the comfort. You know, a lot of times it's a struggle with families of what to do. You know, my grandmother had dementia, so you know, when she couldn't eat or drink anymore, all of a sudden they're like, what do we do? Are we going to put a tube feeding in? Are we going to do IVs? And I'm like, she's been living with dementia for 10 years, so let's not do that. But it was really important for her to be comfortable because I had family going, is she hungry? Is she thirsty? What are we doing? I don't want her to be uncomfortable.
Right.
And that's really what it's all about. So being in my world, I've also seen, you know, a lot of what happens at death, and it can be easier.
Sure.
Instead of harder.
And it's such a benefit to people in healthcare when they have their own loved one, you know, in that final stages of life, because you want to be present as a daughter, as a granddaughter, as a niece, whatever that capacity or role is. And that way you don't have to put your nurse hat on or your home health hat on. You can be their loved one and let hospice come in and be able to help lead you and guide you in the best way possible.
Well, and you don't have to make those decisions at the very end of how much, you know, like, is there enough medication? Is there more? Should I add more? Should I add less? Should I do, you know, I think there's fear around those, what to do in those last moments as a family member. So.
Absolutely. Yes. I mean, how many people really have been with a loved one whenever they've passed? Not a lot. And so all the things that go along with it, it's a very scary time. And when you don't have someone who can help walk you through that time, that moment, it can be very nerve-wracking.
Yeah. Just knowing what to expect, even if you're not ready for it, what to expect.
Right.
So what kind of advice do you have for families?
So the advice that I would have for families is to have an open mind. Do your research, interview several different hospice providers, palliative providers, and make sure you get one that is the best fit for you, because that's what's really going to help with that time and that process. If you have the people that click, you know, the nurse that's going to be in there, the home health aide that's going to be there, those are going to be the two that are going to see your loved one the most. So I would say do your homework, find a good fit for your loved one. And once that happens, just be interactive, be proactive with their care, communicate with the staff so that way you know what's going on. Sometimes we get into a home and we don't see any loved ones until the end. They're there at admission and then they're not there the whole rest of the time. And so sometimes it's hard, you know, to adjust medications. It's hard to do things for that particular patient because we don't have input from their loved ones and they might not be cognitive or alert. So I would say those would be the two things. Do your research and then be interactive once you do have hospice care in the home.
I think that is so important because I think families sometimes want to step back at that moment, but really the more involved you can be with the care team, the better it's going to be for everyone, because sometimes we just need to know the previous insight that they might not be able to give us, or, you know, in some cases, you know, you need to know the family member side and the patient side, because sometimes you got to put a little in the middle.
Right, exactly.
Kind of go from there.
And, you know, I come from a social work background. And so oftentimes we hear, you know, well, family isn't involved. Well, there's a reason for that sometimes, oftentimes actually. And so you have to know the dynamics going into something so that way you can better understand and hopefully mend some things before it's too late.
Right.
And that comes from every ancillary group that goes in there.
Right. Absolutely. So one thing that I talked about on a previous episode, I just mentioned it, is communicating as a patient, communicating with your family if your family is involved, what your desires are. What does death look like to you? And a lot of times people don't want to talk about it.
Right.
And I just think it's so important because, you know, do you want heroic measures? Do you not want? Of course, as you get to hospice, you know, you're not doing too many heroic measures, but you're providing that quality and comfort of, you know, from there. But sometimes families fight that. They get scared in the end and they fight that. So how do you have conversations with families that are on the other on the outs about
Mhm.
what to do next.
So that is a very real situation that we encounter. Another bit of advice I would say is to make sure you have your affairs in order. Make sure you've talked to somebody about your affairs being in order. On a personal level, my mother-in-law went on hospice actually with Heartland, and I was her POA. And her son, who only came up a couple times a year, whenever she was towards the end of her life, had a real struggle, and it was a personal struggle because I think there was a lot of guilt that he felt not being around more.
Right.
And so there was a lot of animosity, believing that we should do more heroic measures, when in fact his mom had a conversation with me 10, 15 years prior about, this is how I want the end of my life to look like. And can you make sure that happens? And if the answer to that was going to be no, then she was going to find somebody else that could.
Right.
And so definitely whenever we go into homes and there is discord, we try to, first of all, we have to go with a POA. If there is a POA, if there is not a POA, that's when our social workers get involved to try and declare if that patient is alert and oriented to be able to sign for a POA, get those paperwork in order. And if not, the state of Missouri has a surrogacy law. And so then we go by that surrogacy law. And then we just try to educate the best we can every time we go in, because sometimes some people get it and some people don't.
I absolutely have seen that many times in my profession too. So, would you like to share anything else, Chris?
Not that I can think of at this time.
All right. Well, Chris with Heartland Hospice, thank you so much for joining me today. And it's been a pleasure. And if you guys have any need for their services or have any more needs, just reach out to me and I'll be sure to connect you.
All right, great. Thank you for having me.
Thank you.